Why and how to use Railway Sheathless Access system for ad hoc percutaneous coronary intervention. I learned Trasradial approach in 2000, and have performed over 9,000 transradial procedure. But in 2019, my patients still suffer from spasm, pain, and at times require access switchover for the same. I have seen my patients suffer pain when insertion or removal of the sheath, at times because of tortuous artery, or at times after performing diagnostic coronary angiography while advancing guide catheter, patients suffer spasm. Despite being aggressive in preventing radial artery occlusion with institution-wide protocols of using thin wall sheath, using adequate heparin dose, and patent hemostasis technique with the concept of minimal amount of pressure for the shortest duration of time. Despite using all this, we still face patients suffering from asymptomatic radial artery occlusion and at times with symptomatic radial artery occlusion. We all know radial artery occlusion leads to failure of reuse of radial access, as well as we cannot use it for hemodialysis fistula. Using the conventional thin wall sheath, I have come across many patients where I cannot use a 7 French thin wall sheath and 7 French guide catheter for coronary intervention, and in some patients even 6 French thin wall sheath and 6 French guide catheter could not be used because patient gets severe spasm from the use of this equipment. This happens because more than likely that at least 50% of your patients will have the radial artery inner diameter smaller than the outer diameter of a 6 French slender sheath. On this graph, what you are seeing is in the leftmost column is a 6 French guide catheter. The second column is the outer diameter of a 6 French slender sheath, and the third column has the outer diameter of a best in market 6 French regular sheath. On these three lines, what you are seeing are the mean diameter of the radial artery reported in population-based data by evaluation with ultrasound. And what you can see is at least 50% of the patients who have their radial artery smaller than this mean diameter reported have their artery smaller than a 6 French sheath, while more than 90% chances that majority of your patients have your radial artery diameter larger than the outer diameter of a 6 French guide catheter. Whenever you insert a sheath that is larger than the inner diameter of the radial artery, it's going to stretch it, expand it, disrupt the intima, leads to activation of the platelet activation as well as coagulation system activation. Whenever the diameter of the sheath is larger than the inner diameter of the artery, the stagnation of the flow also contributes to the formation of the clot and radial artery occlusion, as well as expanding the artery leads to irritation and activation of the adrenergic response, which leads to severe spasm in a highly muscular radial artery. So we know that the outer diameter of a 6 French guide is similar to that of a 4 French sheath. And my goal is to keep this access diameter really small. In a meta-analysis of 66 studies, we had seen that the radial artery occlusion was 11% with a 6 French sheath, while it is only 2% with a 5 French sheath. But my goal is to even keep the radial arteriotomy and the equipment size smaller than that. How can I do that? I use 5 French thin wall sheath for my diagnostic coronary angiography. So I accept the 5 French diagnostic catheter angiography for my patients. So I use 5 French thin wall sheath, which has an outer diameter of 2.08 millimeter. And after completing the diagnostic procedure, if I am going to do intervention, I prefer to do intervention with a 6 French guide catheter, as majority of the operators across the globe, across the world, where majority of the people like use 6 French guide catheter. Similarly, I want to use 6 French guide catheter for my PCI in majority of the patients. And the outer diameter of a 6 French guide catheter is 2 millimeter. So using Railway Sheathless Access system, I can exchange the thin wall 5 French sheath with a 6 French guide catheter, and that's how I can keep my arteriotomy and equipment size less than 2.1 millimeter, and therefore there will be more than 90% chance that my equipments were smaller than the inner diameter of the radial artery, and therefore by keeping this ratio of less than 1, I can reduce or eliminate pain, spasm, radial artery occlusion, and even be able to use 7 French guide catheter with 7 French Railway Sheathless Access system, because the outer diameter of that system would be same as a 5 French sheath. So by essentially reducing arteriotomy by 2 French by using sheathless access system, I can really limit the limitations of, or keep the limitation of the radial artery access minimal. How do I do that? You want to keep your assembly of the guide catheter and dilator ready. So on the Railway Sheathless Access system, there are 2 dilators. There is a 0.021 inch dilator and there is a 0.035 inch dilator. Because you are converting after a diagnostic procedure for an ad hoc PCI, you want to get your 0.035 dilator inserted in a guide catheter with a backloading prepared for the PCI. So I keep my assembly prepared as seen here. This railway dilator can be used with multiple brand guide catheters. I have used Railway 6-French dilator with a 6-French guide catheter from Medtronic, Cordis, and Terumo, and it works well with all of the guide catheter. So you keep this guide catheter assembly ready. The tip of this 035 dilator has a hydrophilic coating and it gives a perfect transition from a 035 wire to the dilator and nearly perfect transition from the dilator to the guide catheter. So here I have completed a diagnostic coronary angiography using a 5 French slender sheath and 5 French diagnostic catheters. Now I want to convert this into a 6 French guide catheter percutaneous intervention. So I'm removing the sheath while applying gentle pressure on the wrist. Once this is done, after wiping the wire, I am making a skin stab with a blade in a very horizontal, shallow advancement of the blade to just make a skin nick. This skin nick is absolutely essential in my opinion to perform seamless or smooth procedure with the railway access system. So after performing this skin nick, you want to load your assembly that you kept prepared on 035 wire, and your assistance is now helping you keep the wire with a straight rail and pushing the assembly together. You can see how easily the dilator and guide catheter entered through the radial artery. Your assistant has to make sure to hold a straight rail with the wire and also to hold the assembly of the dilator and catheter in the same relationship while you are advancing the guide catheter up to the subclavian artery. When you reach the subclavian artery, you want to hold your wire and dilator and allow the guide catheter to enter the ascending aorta. And this is how you can perform an ad hoc PCI after diagnostic catheter using the Railway Sheathless Access system and keep your arteriotomy really small. Here is an example. After performing diagnostic procedure with a 5 French catheter, I wanted to intervene on this Marina class 011 lesion with a diameter mismatch of the main artery with the side branches. So I wanted to do simultaneous kissing stent. So I upgraded from a 5 French thin wall sheath with a 7 French Railway Sheathless Access system and a guide catheter and use 2.5 mm drug-eluting stents simultaneously in a simultaneous kissing stent fashion. So similarly, you can perform many other complex interventions using 7 French system or your routine intervention or with at your comfort level using a 6 French guide catheter to perform ad hoc PCI. This is how you can keep your arteriotomy small, your equipment small, avoid stretching, expanding or disrupting the radial artery and reduce the limitations of the radial access. Thank you.